Okay, Alexander, we're ready. Okay,
Yes,
thank you.
Yeah.
Dear colleagues, dear scientists, good afternoon. It gives me great pleasure to welcome you all to our hybrid event, New Frontiers in Cardiac CT and Cardiac MRI, Myocardial Perfusion Imaging, Learning with the Experts. My name is Athanasios Natsios. I am the Medical Director of Eastern Europe at GE Healthcare, and I will be your co-moderator today with Dr. Alexandros Kalifatidis. Our scientific panel, by renowned experts in the field of cardiology and radiology, will share with us their experience and the latest developments. And furthermore, at the second session, several interesting cases with a voting system will deepen our expertise and knowledge interactively. And don't forget the take-home messages in which our speakers will provide the most valuable insights in their field of expertise. Throughout the workshop, you can submit your questions using the relevant Q&A button at the platform. All the questions will be answered during and at the end of the event. Thank you very much for listening, and let us welcome our co-moderator, Dr. Alexandros Kalifatidis.
Thank you very much, Thanos, for the kind introduction. Good afternoon, ladies and gentlemen, dear colleagues and friends. I'm really excited and very happy for this scientific event organized by General Electric Healthcare. And I would like to sincerely thank all the people from General Electric and, of course, to congratulate them for the initiative and for this organization. And, of course, special thanks also to Dr. Athanasios Natsios. I'm really happy because we are among very good friends at first and excellent colleagues. And since the time already has started, I would like to introduce our first speaker. It is Dr. Evstratios Theophilogannakos. He's a consultant cardiologist at St. Luke's Hospital here in Thessaloniki, and he's specialized in advanced cardiovascular imaging as well as in advanced heart failure. So, Dr. Theophilogannakos will talk us about the ischemic heart disease, and he will make us an overview and a clinical update. So, Stratos, the scene is yours.
Thank you very much, Alexandre. Initially, I want to thank GE Company for the kind invitation to participate in this interesting, I hope so, meeting. My topic is ischemic heart disease, a clinical update. So let's start from an introduction and some definitions. Ischemic heart disease is a pathological condition characterized by reduced cardiac blood flow that causes a mismatch between myocardial oxygen supply and demand. The underlying pathological process is most frequently coronary artery disease due to atherosclerotic obstruction or spasm. Therefore, we can say that ischemic heart disease and coronary artery disease are terminologically often used synonymously. And let's see some things about epidemiology. We know that ischemic heart disease remains the leading cause of mortality and morbidity worldwide, causing more than 9 million deaths per year globally. We can see from these two graphs that the prevalence of coronary heart disease increases rapidly with advancing age. So we can say that coronary heart disease affects mainly the elderly. And also, the second conclusion from these two graphs is that the prevalence of coronary heart disease was higher for males than females for all ages. However, the last 50 years, because of an improvement mainly in primary prevention, we have a reduction of incidence of coronary artery disease, especially in developed countries, as we can see from these graphs. Moreover, decline in deaths from cardiovascular disease in relation to scientific advances has already reported the last 60 years. This timeline shows the steady decline in cardiovascular deaths over the last 60 years, along with major advances in cardiovascular science and medicine, as for example, the first heart operation, the first coronary angiography in early 60s, the first angioplasty in the late 70s from Grunzing, and of course all the big trials that have introduced at least 5 significant medicines that have changed the prognosis of patients with ischemic heart disease, as for example, beta blockers, statins, clopidogrel, etc. The pathogenic mechanism of myocardial ischemia is mainly the atherosclerotic disease of epicardial coronary arteries. Sometimes there is also a vasospastic disease of epicardial arteries, and in less common, a microvascular dysfunction can contribute to ischemia of the heart. The clinical spectrum of ischemic heart disease has 2 main manifestations, major manifestations. The first one is the stable coronary artery disease. That's about 75% of cases, and the rest, 25%, is acute coronary syndromes. The last 5 years, there is a change in the nomenclature from stable coronary artery disease to chronic coronary syndromes. This is a big, not only terminology change, in order to show us better the pathophysiology of the disease. So the rationale is in that, in this change in the name of the disease, is that although coronary artery disease is often stable in between acute events, the underlying disease status is anything but stable. So we know that atherosclerotic plaque accumulation is a dynamic process that can change over time to include growth, stabilization, or regression, as well as changes in plaque composition or thrombosis. So the last 5 years, we have changed the term from stable coronary artery disease to chronic coronary syndromes in order to have a better knowledge of pathophysiology. And the current guidelines for this reason, the guidelines of 2019, have changed the terminology from stable coronary artery disease to chronic coronary syndromes. Let's see what is the proposed approach from the European Society Cardiology guidelines for the initial diagnostic management of patients with angina and suspected coronary artery disease. So there are 6 different steps. The step 1 in the step 1, we must assess the symptoms and perform clinical investigation. If the diagnosis is unstable angina, we must follow the acute coronary syndromes guidelines. The step 2 is to consider comorbidities, quality of life, and life expectancy. In the step 3, there are the resting ECG, biochemistry, chest X-ray in selected patients, and echocardiography at rest. The step 4 is very critical and very crucial for the management of our patients, is to assess the pre-test probability and clinical likelihood of coronary artery disease. In the 5th step, we must choose the best the best technique in order to screen our patient, and finally the step 6 to choose appropriate therapy based on symptoms and event risk. So first one, symptoms and signs. It's very important because we know that a careful history is the cornerstone of the diagnosis of angina. In the table we can see that there is a traditional clinical manifestation of suspected anginal symptoms. So if the pain meets the following 3 characteristics of typical angina, that means constricted discomfort in the front, precipitated by physical exertion, and relieved by rest or night race, we can say that we have a patient with typical angina. If the chest pain meets 2 of these characteristics, then we can say that we have a typical angina, and finally, if the pain of our patient has only 1 and none of these characteristics, we can say that the pain is not anginal. The step 2 is important in order to access comorbidities, other causes of symptoms, and mainly the life expectancy of our patient. This is very important for the management of our patient, given that if we have, for example, a patient with very short life expectancy because of a generalized cancer or something else, the revascularization is unlikely to be an acceptable option for this patient, and further testing may be reduced to a clinically indicated minimum. Step 3 includes basic tests. That means the standard laboratory biochemical testing, the resting ECG, the resting echocardiography, and in some cases, chest X-ray. And these are the recommendations for the blood test in a patient with suspected coronary artery disease. First of all, we must evaluate the possibility of clinical instability or an acute coronary syndrome. So that means that we have to have repeated measurements of troponin in order to exclude acute coronary syndromes. All patients must have the following blood test in the setting of acute coronary syndrome. Full blood count, creatinine measurement, a lipid profile, as well as screening for type 2 diabetes and thyroid hormones. A 12-lead ECG is recommended, of course, in all patients with chest pain. And also a resting transthoracic echocardiogram is recommended in all patients in order to exclude alternative causes of angina, for example, severe aortic stenosis or hypertrophic obstructive cardiomyopathy, in order to identify regional wall motions abnormalities suggestive of coronary artery disease, to measure LV ejection fraction, that is very important, as we know, for risk stratification of our patients, and finally, to evaluate diastolic function. And finally, chest X-ray is recommended in some cases of our patients, especially to exclude pulmonary disease, as for example, pneumothorax. Step 4 is maybe the most important step in order to decide what is the best option for our patient, according to the test that we must do. We know very well that the likelihood of obstructive coronary artery disease is influenced by the prevalence of the disease in the population study, as well as by clinical features of an individual patient. And the most important thing is that the diagnostic testing is most useful when the likelihood is intermediate. This is a table that shows us a simple predictive model that we can use it in order to estimate the pretest probability of obstructive coronary artery disease based only on 3 parameters: age, sex, and the nature of symptoms. But apart from this easy model, we can know that there are some other informations that may decrease or may increase the likelihood of coronary artery disease. For example, if our patient has normal exercise ECG or no coronary calcification in CT angiography, this fact reduces the clinical likelihood of coronary artery disease. On the other side, if our patient has many risk factors for cardiovascular diseases and ischemic heart disease, for example, dyslipidemia, diabetes, hypertension, smoking, etc., resting ECG changes, LV dysfunction suggestive of coronary artery disease, abnormal exercise ECG, or coronary calcium in CT angiography, all these things increase more the clinical likelihood of coronary artery disease. And in step 5, we must decide what is the best exam for our patient. We have 2 strategies, the anatomical one and the functional strategy. And the anatomical strategy includes coronary CT angiography, CT coronary angiography, and invasive coronary angiography, while the functional strategy includes stress exercise test, ECG exercise stress test, stress echo, SPECT, and stress CMR. And this is an algorithm that the European Society of Cardiology proposed in order to decide what is the best option for each patient. It's a little complicated. In general, we can say that coronary CT angiography is the best test for patients with a lower range of clinical likelihood of coronary artery disease, with no previous diagnosis of coronary artery disease, and with good characteristics associated with high likelihood of good images. From the other side, invasive coronary angiography is recommended in high clinical likelihood of coronary artery disease and in patients also with severe symptoms. Finally, functional non-invasive testing may be preferred in patients at the higher end of the range of clinical likelihood and also for patients with previously diagnosed coronary artery disease. The problem is what we must do for patients with intermediate probability of coronary artery disease. So this paper proposed an algorithm that says to us that if the patient is in low intermediate probability of coronary artery disease, that means below 65, possibility below 65%, the best choice is the coronary CT angiography. If the patient is in high intermediate probability of coronary artery disease, then we have best choice from functional tests, for example, CMR, echo, or SPECT. In this table, we can see the characteristics and compare the characteristics between the tests that commonly used to diagnose the presence of coronary artery disease. As you can see, exercise ECG has very low sensitivity, but it has good specificity. The functional tests have very good sensitivity and specificity. And finally, the coronary CT angiography has very, very high sensitivity with moderate specificity. Exercise ECG test, because of the limited power to rule in or rule out obstructive coronary artery disease, its significance has reduced in the current guidelines. You can see that in the table that in the guidelines of European Society of Cardiology from 2013, there was a stroke indication with class 1 to do exercise ECG in patients with symptoms and intermediate pre-test probability. But now this indication is very, very weak, only 2B. That means that according to the current guidelines, other tests have been proposed as better choices. And we can see analytically, non-invasive functional imaging for myocardial ischemia or coronary CT angiography is recommended as the initial test to diagnose coronary artery disease symptomatic patient in whom obstructive coronary artery disease cannot be excluded by clinical assessment alone. It is recommended, as we have already discussed, that the initial non-invasive diagnostic test is done based on the clinical likelihood of coronary artery disease and the pre-test probability. Functional imaging, for example, stress EMR or stress echo, for myocardial ischemia is recommended if coronary CT angiography has shown coronary artery disease of certain functional significance or is not diagnostic. As I have already said, invasive coronary angiography is recommended for patients with high clinical likelihood and severe symptoms. And finally, coronary CT angiography is not recommended when extensive coronary calcification, irregular heart rate, significant obesity, inability to cooperate with breath hold commands, or any other condition make obtain good images quality unlikely. And here, the techniques that we have and the advantages and disadvantages. So you can see that echocardiography has wide access, there is no radiation, the cost is very low, but as we know, the images are dependent on the operator skills. SPECT has also wide access, but there is a problem of radiation. CMR gives us very good high soft tissue contrast images, but there is a problem of functional analysis limited in arrhythmias. And finally, coronary CT angiography, we know that we have very, very good results in patients with low pretest probability, but there is the problem again as the SPECT with radiation. There was a big trial that compared the anatomical versus functional diagnostic strategies in symptomatic patients with suspected coronary artery disease. The trial was a PROMISE trial. About 10,000 patients with stable coronary artery disease randomized in two arms. The first one, the anatomical one, with a CTA angiography, and the second one, the functional one, with exercise ECG and pharmacological stress imaging. And as we can see, there is no difference in the primary endpoint, death, myocardial infarction, unstable angina, and major complications. There were some differences in the secondary endpoints, and in conclusion, this big trial said to us that there was no significant difference in outcomes between an initial anatomic or functional strategy, but an initial CT angiography strategy was associated with a lower rate of invasive catheterization without obstructive coronary artery disease. But we have the problem with the radiation exposure that it was higher, of course, in CTA arm. Few words about the recommendations for the treatment of stable coronary artery disease or chronic coronary syndromes. Of course, we must change the lifestyle of our patient. And we have also some drugs, as for example, aspirin, clopidogrel, statins, AC inhibitors, in order to improve their prognosis. And the big issue and the big question is there any position for revascularization in patients with stable coronary artery disease, and does ischemia matter? So this was a big trial, the CARDS trial, 15 years ago, that surprisingly, it was a negative trial. So this trial concluded that percutaneous coronary intervention did not reduce the risk of death, myocardial infarction, or other major cardiovascular event when added to optimal medical therapy in patients with severe but stable coronary artery disease. After that, very recently, 2 years ago, one bigger, even bigger trial tried to prove the importance of revascularization in stable coronary artery disease, and the result was the same. So there was no difference between the conservative strategy and the invasive strategy according to death and myocardial infarction. And the conclusion of the authors was that they didn't find evidence that the initial invasive strategy reduced the risk of ischemic cardiovascular events or death from any cause. The result of this, and from the previous one, trial, showed to us that optimal medical treatment is the cornerstone of patient management in stable coronary settings. The other form that ischemic heart disease can be manifested is acute coronary syndrome. There are 3 different acute coronary syndromes: unstable angina, ST elevation myocardial infarction, and non-ST elevation myocardial infarction. We can see that in unstable angina and in non-ST elevation myocardial infarction, there are non-occlusive thrombus in the culprit lesion, while in the STEMI, with ST elevation in ECG, there was complete thrombus occlusion in the culprit vessel. In unstable angina, we don't have specific ECG changes, while in non-ST elevation, we can find ST depression or T wave inversions. And of course, in the STEMI, the ST elevation is a typical ECG that gives us the definite diagnosis. In unstable angina, the enzymes are normal, while in the 2 types of myocardial infarction, of course, we have elevated cardiac enzymes. In almost cases of acute coronary syndromes, the patients present with acute chest pain. And we know that's a big problem in the ED, because there are many different diagnoses that can cause this type of chest pain. Apart from acute coronary syndrome, stable angina, pulmonary embolism, aortic dissection, pericarditis can cause also acute heart pain. And there are also some non-cardiac causes, as for example pneumonia, panic disorders, and musculoskeletal pain. When we have a patient with acute chest pain in emergency department, the challenge is to rapidly identify the patient who require admission and urgent management. And apart from the type of chest pain, the past medical history, the ECG, the enzymes, and the echo help us to have a definite diagnosis. This is an algorithm for triage in acute coronary syndrome that has been proposed from European Society of Cardiology. We can see that the clinical setting symptoms, the ECG, and the levels of troponin are the 3 things that will make us the diagnosis. Step 1 is again symptoms and medical history, but we can see that chest pressure has low sensitivity, only 66%, and lower specificity, 36%. That means that we can't have the diagnosis only with the pain. This is a typical ECG, an easy case for ST elevation myocardial infarction. And of course, if we have this type of ECG, the patient must be immediately transferred to the cath lab. But unfortunately, only 5% of patients have these typical ECG findings. And we know that ECG has a number of limitations, low diagnostic sensitivity for acute coronary syndromes, and also we know that about 10% of patients with myocardial infarction have absolutely normal findings on ECG. Step 3 is, of course, a biomarker, and mainly the troponin, the high-sensitivity troponin that we have now. But we must know also that there are many extra cardiac and reasons that a patient have increased levels of troponin without acute coronary syndromes. And this is the proposed diagnostic algorithm for patients with suspected non-ST elevation acute coronary syndrome. And as we can see, the levels of troponin is critical in order to rule out or rule in the diagnosis of acute coronary syndrome. And a few words about the recommendations for imaging in patients with suspected acute coronary syndromes. Of course, 12-lead ECG is critical. Echocardiography also can help us to have diagnosis. And in patients with no recurrence of chest pain, normal ECG finding and normal levels of cardiac troponin, but still with a suspected acute coronary syndrome, a non-invasive stress test, preferably with imaging for reducible ischemia, or coronary CT angiography is recommended before deciding on an invasive approach. And finally, in the acute coronary syndromes, the clinical recommendations are totally different than in the stable coronary artery disease. Here, we must reperfuse immediately the patient, preferably with primary PCI. And also, in all types of acute coronary syndromes, parenteral anticoagulation and antiplatelet therapy are critical in the management of our patients. So, in conclusion, the change of terminology from stable coronary artery disease to chronic coronary syndromes has been proposed to more accurately represent the changing pathophysiology. Although the mortality from cardiovascular disease is decreasing, it remains the most common cause of death worldwide. Clinical spectrum of ischemic heart disease includes chronic and acute coronary syndromes. Non-invasive functional imaging for myocardial ischemia or coronary CT angiography is recommended as the initial test to diagnose coronary artery disease in symptomatic patients. Selection of the initial non-invasive diagnostic test is done based on the clinical likelihood of coronary artery disease, as well as local expertise and the availability of the tests. Invasive coronary angiography is recommended in patients with a high clinical likelihood and severe symptoms. Exercise ECG test may be considered with low, with not very strong indication now as an alternative test to rule in and rule out coronary artery disease when non-invasive imaging is not available. CT angiography is quick and particularly useful in ruling out obstructive coronary artery disease, particularly in patients with low pretest probability, while SPECT and stress echo are both relatively cheap and widely available. CMR and CT may become more attractive for routine clinical practice. We know that CMR provide us more information on myocardial structure and function. Thank you very much for your attention.
Thank you so much, Dr. Evstratios Philogiannakos, for this excellent overview covering all the spectrum of this very current disease, coronary artery disease, remain the first cause of death in the West world, and showing us all these valuable tools that we can use in order to get the final right diagnosis. And I think that we have some time for 1-2 questions.
Yeah, correct.
Thanos?
Yeah, we have a question from the web audience. So it says, what imaging modality do you suggest as first option?
As?
First option.
It depends on the patient, depends on the pretest probability. This was the main conclusion of this speech. So if we have a patient with low pretest probability of coronary artery disease, that means a patient that is quite young without many risk factors for coronary artery disease, the best choice is the coronary CT angiography. If we have a patient with known coronary artery disease with previous revascularization, etc., the best choice is a functional imaging.
Thank you for your explanation. And if we have a question from the audience, you can use your microphone that is seated near you. Otherwise, we can proceed to the next speech.
Yes, only one fast question, Stratos, because we are working very oftenly also together in the hospital. And as you said, in the emergency department, sometimes it is difficult to rule out or rule in coronary artery disease, but how easily you can implement this advanced, for example, cardiac CT examination in the emergency department in general, in public hospitals, in Greece, in Europe, in the
I
world.
don't know if in general, but in our hospital we can do it quite easily because of you mainly. But okay, in general I think that if the pain is typical, but the ECG is normal, and also biomarkers are negative, then the next choice is a coronary CT angiography. If, of course, if the patient has positive biomarkers, the option is an invasive one, invasive coronary angiography. And I think that it's very easy way in order to exclude coronary artery disease in the ED if you have the opportunity to have immediate access to CT angiography.
And that shows that we need much more people that have to be trained in this technique, because you show us in an excellent way also according to the guidelines that it is a very important tool, first tool, imaging tool, sometime in many clinical scenarios, also in the emergency department.
And also, as you know better, with the CT angiography, we can exclude also aortic dissection and pulmonary embolism. So it's an unbelievable good rule-out technique for all the acute heart events, episodes.
Many, many thanks. I don't know if we have other questions. If not, we can proceed with our next speaker, a very good friend and colleague, a very experienced colleague, Dr. Konstantinos Michailidis. He's a cardiac radiologist, board certified by the European Society of Cardiovascular Radiology. He has a huge experience in cardiac CT, and he will show us some tips, and he will talk us about the technical basics, protocols, strategies in order to proceed further with dose reduction and about the contrast media in cardiac CT. So, Dr. Michailidis, Kostas, you have the microphone.
Thank you, Alexandros. Thank you all for being here today. And I want to thank the audience that are watching us from distance and will have maybe the chance to watch this thing on demand later. But of course, I want to thank General Electric Healthcare that give us the opportunity to come close to you, to share our experience and knowledge and try to advance in this very charming field of cardiac CT, cardiac imaging, cardiac MRI. And of course, get familiar with the new stress techniques, and that is the main topic of today's event. I'm going to present some, I'm going to base my topic in continuation from what Dr. Theophilogannakos very successfully presented, the clinical situation about coronary artery disease and the utility of all the methods, but he really supported cardiac CT a lot as a first option that is supported by the guidelines, obviously. And I'm going to talk about the bad things of coronary artery CT, not the nice images, all the difficult things that we have to overcome in order to achieve high quality images and a very robust clinical report. So I'm going to discuss about the basics. I'm going to share with you some protocols, of course, cardiac CT and some other things, dose reduction strategy, because it's really important that we achieve high doses of contrast and radiation. And I'm going to talk about contrast media. I have to talk about my disclosures. I have delivered educational coronaria for GE Healthcare and Bayer Healthcare, and I'm working with Circle CVI on developing some artificial, I have been sponsored with hardware and software by Circle CVI. I take the opportunity to say a very great thanks to Eva Mrazova. She's application specialist for GE. She visited me in 2016 in Kozani when I started performing cardiac CT, and she changed everything for me. She changed the perspective. She gave me so much experience in performing high quality studies and utilize these concepts of low dose, low contrast, and high quality images. And I also want to thank Vasiliki Panali. She was a GE representative that brought us closer to you, to GE Pharmaceutical. Okay, so I'm gonna make a very short overview about the about the history of the method that started in 1967 with Sir Godfrey Hounsfield. Proceeded a lot of new innovations. 1989, we had helical CTs and later on multi-slice CT scanners, and things were getting better and larger scanners, low radiation, higher heart rates that we could achieve high quality images and very low doses. And so all these things brought us close in achieving high and good reports. And of course, the difficult thing about getting these nice images was that the heart moves a lot. It moves in 3 different directions by the heartbeat, by the intrinsic motion of the heart, and it's also moving along the diaphragm up and down in a vertical direction. So in order to achieve, we radiologists know well that we have to find something in a stable condition that is steady, that is not moving, in order to achieve high quality images. And of course has to do with the performance of the scanner, but has to do with the characteristics of the patient. I'm going to use some MRI images to try to show you that, as we see here in the 4-chamber view, that the heart beats, when the heart beats slowly, about 60 beats per minute. The time that the heart stays stable, the longest period that it stays stable, it's the mid-diastolic period, about 60 to 70% of the cardiac cycle as we know it by CT angiography. And in 60 or 55 beats per minute, the time that it remains stable is about 200 milliseconds, which is the temporal resolution of most scanners. If we start from the beginning, this method was developed using retrograde retrospective gating. That means that the scanner was acquiring images throughout the cardiac cycle, and that would mean a lot of radiation. The next step was using retrospective gating with ECG modulation, targeting the specific heart rates to get high quality images, thus lowering the radiation significantly. And of course that getting retrospective examinations give us the potential to see in very good temporal resolution moving heart and moving structures. So we can see a very nice 4-chamber view here in this situation, and we can see also the bicuspid aortic valve on the right side. But of course, this is all happening at the cost of high radiation, and because the method has a lot of, it's going to be applied in a lot of patients. Maybe in the future we will see mass screening using this method. Low radiation was something really important that we had to keep in developing these methods. So as we can see here again in this scheme, on the upper left corner, we can see the retrospective. Then we had the first prospective scans. At the beginning, the prospective was targeted prospective scans at specific, depending on the heart rate, specific time zones in the cardiac cycle. Later on, the development brought prospective gating with padding. That means that during the scan, if there was a change, a major change in the heart rate, the scanner would adapt to it and change the padding. It would increase the padding or keep it low. And that we know it's really important because, of course, it is important to prepare our patients well. But a lot of times things are a little unpredictable. And even though the things go well, you start having arrhythmia or tachycardia or something like this. The flash scan is made by only one vendor, and it's not very widely used. We can see here on the left side, we have a heart beating at 60 beats per minute, and as we said, we acquire high-quality, steady images at about 70 to 80% of the cardiac cycle. On the right side, we can see a heart beating fast, and in this situation, the heart rate is about 80. In this situation, the time that the heart spends steady is mostly in end systole, so about 30 to 40% of the cardiac cycle. And in this diagram, we can see that how changing the heart rate affects the temporal resolution on which we can acquire images. So we can see here that if the heart rate is about 45 beats per minute, we have 500 milliseconds to acquire good images. That means we can get very nicely and easily high quality images, but this is rarely the situation. At 60 beats per minute or 65 is about 250 milliseconds, which is very good time for most scanners to acquire excellent images. And of course, going higher than 80 beats per minute, then the time is not sufficient, and only a few very dedicated scanners can achieve that. However, even if with the highest and biggest scanners and highest raw technology available, in all situations, a target will be to achieve a heart rate of 60. I mean, even with these very modern and nice scanners, if you go 80 beats per minute, the patient, then the quality of the images are not going to be as good, and of course the expenditure of radiation is going to be higher. So right now the cornerstone of performing this right is to have to regulate your patient correctly, to prepare your patient correctly and achieve a heart rate below 65 beats per minute and acquire diastolic prospective studies, images. If the heart rate is above 65 and less than 75, however it is rhythmic, you can acquire excellent systolic imaging, prospective systolic images. You do not have to go retrospective. And trying to proceed with talking about the protocols, we are going to say, I'm going to have a very brief comment on a calcium score that is it is a scan that precedes usually the coronary angiography. I think it is really important to remember to perform a calcium score including all lung fields, not only the heart, because the comorbidities are there and you can find some things that you cannot imagine but will give you a very good question to your patient. Here is a 42-year-old patient that has no risk factors, but she was experiencing continuous dyspnea and fatigue, and so you can see here that low quality, low dose images of the upper chest who show some biconcave appearance of the thymus that could very well be some thymoma. Some other tips about calcium score is that it is a prospective study always. We can do it with higher detector widths. We should scan low kilovoltage in most patients to achieve very low radiation, and we can see lung excellently. And of course we can detect with lower voltages, we can detect calcium easier. And we have to recon the whole field of view so we can make comments about the lungs, especially for the smokers. Proceeding with coronary CT angiography, again, it is a prospective study. It should not be done retrospectively. Here I give my suggestions about the heart rate and which prospective moments in time we should target. So for somebody that goes less than 55 beats per minute, doing a prospective study is quite tricky, and you should be very careful with them because there is very useful, very frequently step artifacts in these patients with very low heart rates. The rate that we want to see is about 55 to 60 beats per minute. Then we'll have excellent images between 70 and 80%. Only 10% of the cycle we can achieve excellent images. And accordingly, if the heart rate goes to 70 up to 78, as I told you before, we can go to and target 30 to 45%. And of course, the coverage in the Z-axis, we should not include the whole thorax and the whole mediastinum just to see the coronary arteries. We have to go straight to the coronary arteries, 1 centimeter above the uppermost and just to the end of the lowermost coronary artery. I will give you some suggestions on about protocols, how make decisions about what kind of how I'm gonna regulate my kilovoltage and my amperes, my current. So I use this this algorithm in that I take in account the patient's BMI and the patient's calcium score. And the bigger the BMI and the bigger the calcium score, then we need bigger radiation and bigger energy to achieve high quality images and be able to detect what is calcium, what is plaque, what is fibrous plaque, and what is lumen. So basically, most of the job of ECG-gated CT is coronary CT angiography, but there are some other dedicated scans that we can do, and they are quite frequently, like TAVI planning, triple rule out, some studies to assess the function of LV and RV, congenital and adult congenital studies, stress CT, and planning for electrophysiological procedures. All of these studies are retrospective. They need extensive coverage. It's a different story with radiation. In this situation, we have patients, they are not examinees, who have to give an answer. So radiation is not the most important thing. Obviously, we have to practice according to ALARA, but we have to get very good quality images in order to answer the problem. And I would tell you that a very important thing, especially about TAVI patients, because they have decreased renal function, is to do single injection protocols, not double injection protocols for TAVI patients. And I'm gonna, as today's most important has to do with ischemia, I'm gonna talk about stress CT a little bit. In 2019, the Society of Cardiac CT released this expert consensus document on about stress CT and how we should perform it and interpret it. In this expert consensus document, what they say is that this is the diagram very nicely shows how we make decision on how to perform the study. At the beginning, we do the pre-assessment, the clinical pre-assessment, as Dr. Theofilogiannakos said, and then depending on calcium score and the pre-test probability, we make a decision to go first for stress, which is the lower protocol they suggest, or in the upper situation, that is that we have low pre-test probability, we perform a CT angiography, and then depending on what is on there, if we see a critical or borderline stenosis, then we can do a stress. So that means we inject some recadenosone straight away, and then we acquire one, either depending on our scanner, some multi-phase perfusion or single-phase perfusion, we can make a decision. And this is actually one-stop shop. This is what cardiology is dreaming of, like to do one study and give all the answer about anatomy, about vulnerable plaque and ischemia. The other way that we can proceed with this is do first stress. So for high-risk patients, do firstly the stress, so give recadenosone and acquire stress images. And then in case that it is negative, we can proceed with anatomic images to see if there is any vulnerable plaque, so we can decide on the level of prevention. So the different types of perfusion, CD perfusion, are compared here with the different advantages and disadvantages. You can very nicely see in this paper that is free access from the Society of Cardiac CT website. And, but I want to stress here that one of the issues performing stress is the dual injection, the dual vein, the dual intubation that we might need. That makes things a little difficult. And previously with adenosine, what make it harder to achieve targets. Now recadenosone is very easy to use with a bolus injection, and then we acquire images at a specific time. And from the experience our colleagues have, they always have very good strength response. And it is better tolerated by the patient. So here I will show you some images on the left side. We can see the anatomy, that will have some significant stenosis both in the right coronary artery and the LAD. And then here we can see how nicely the perfusion defects are shown in the lower wall. And here we can also see necrotic myocardium, so we can also see myocardial infarction and ischemia here. And this is done with a multiphasic technique that has transient attenuation curves. The single-phase technique is a little bit more easy to post-process because we only have one set of images that is static, and this bullseye representation is created by the software where the perfusion is decreased. So it's only one phase that it is sufficient. Most of the departments that perform the method do this technique, like only one phase, just to decrease radiation. And a very interesting study goes on right now in Europe testing the efficacy of this stress CT in real clinical scenario. Now, proceeding with those reduction strategies, I want to tell you that it's really important to adhere with these concepts. I mean, we cannot do CT, CA, and give 1,000 DLP of radiation. This is very high radiation. This is 25 millisievert. It could be substituted by 3 SPECT and 2 interventional radiology. You understand that in order to perform the study, the quality of the study has to do with low dose and low contrast studies. You cannot do it out of the range. Because as you can see here, that performing a retrospective study, the amount of radiation that you give is at least 15 millisievert. When you do a prospective study, even if they are both on 120 kVs, is about 1/8 is about 2 millisievert. And you understand that a lot of times our patients is young ladies, that breast is also on the pathway of the radiation. So the European Society of Cardiology in 2018 released this document about reducing radiation in all different imaging modalities. That means SPECT, CT, and basically these two, and how we could achieve that, and PET. And so what they say about CT, and I think this is the most important thing, consider a trade-off between higher image noise and lower contrast resolution. That means that radiologists and cardiologists practicing the method, they have to be familiar with some noise, just doing it for the patient's benefit, in decreasing the radiation, in serving this method in a better way. It has to be low dose. And my personal view about this on how we can reduce the dose reduction strategy, and this includes contrast dose and radiation dose, has to do with trying to regulate our patient's heart rate at our goals, which is 60 beats per minute. To set up our scanner and parameters of the scanning parameters depending on basis BMI and the patient's calcium score. And always use appropriate scanning settings and the appropriate number of contrast. These are my proposals, which are based on the CCT proposals on how to regulate heart rhythm, which is mostly done with PEROS or IV metoprolol, and here I have some of the protocols that I suggest depending on the heart rate. IV metoprolol, I think it's a very good idea because we can titrate the heart rate so we do not have a very significant bradycardia, and it's better tolerated by the patients. I also want to stress the use of ivabradine, which is a very, very, very safe drug. It's a very good idea for all radiologists to use. It's very safe to use, and the efficacy is very well tested. It has documentation to be used in CT angiography. And we can use it as double dose 2 hours before the scan, or single doses, so that means 4 doses in 2 days, day and night, in people that have a high heart rate, and works really well. This job belongs to the radiologist or to the cardiologist who's going to perform the scan. That means that the person who's going to interpret the study has to regulate the heart rate. It cannot be done by the cardiologist at his office, because the cardiologist has to make sure that the heart rate is going to be normal while the patient is at home. When the patient comes in the CT department, is going to have a high heart rate anyway, and we'll have to regulate, we'll have to make, to normalize this heart rate to 60 beats per minute. But we need the help from the cardiologist if the heart rate is above 100, if we have a high rate atrial fibrillation, or if we have very high extrasystolic activity. One of the things that we have to stress is that we always have to give GTN, we have to give nitrates before a coronary CT angiography. Coronary CT angiography should not be performed without nitrates. And as I told you before, that we calculate BMI and the calcium score before we decide the parameters that we scan during the CT angiography. One of the things that it's a very good thing to be careful about, is not to use inappropriate low kV. So like we should not use 80 kV in a patient with a BMI of 35, because that will increase the current a lot, and in the end we will not achieve any reduction in radiation. So we cannot just, we have to have some principles on how low we can go. Now about contrast. A very good contrast enhancement is one of the high-quality targets. So we target more than 300 Hounsfield in ascending thoracic aorta, and I suggest that enhancement should not exceed 450 Hounsfield. 450 is very close to calcium, which is 600. And then we're not going to be able to differentiate between lumen, plaque, and calcium. So in very high contrast, amount of contrast is going to be a problem. It's not useful. I also say that we should not have contrast in the superior vena cava, because that will make artifact and might cause some problems, and very low contrast in the right ventricle. Of course, we have to use high contrast, high concentration of contrast, because coronary arteries are really small, and we have to increase their opacity. And we also have to achieve high flow rates, so it's a very good idea to cannulate above the level of the elbow. And I personally suggest never use test bolus. Now with the neuroscanners, we should always use enhancement triggering. 10 mL of contrast go wasted by test bolus. So one more thing about concerning the contrast has to do with that we think, we suggest that we always have to warm up the contrast, because their viscosity from 20 degrees Celsius to 37 is halved. It's half the viscosity, so the contrast will flow much better, and we're not going to have extravasation or like even like some problem with the veins and pain and whatever that means. And this happens with most contrast media. But what is very important to remember, and that has to do with coronary CT angiography, is that no other study is so much related to the patient's emotions. So if during the study the patient feels frightened, that is going to increase the heart rate, and that is going to damage the study. So isosmolar agents like iodexol is really good with that, decreasing the thermal sensation and the vomiting sensation, or even the iodine taste of the contrast that I recently had when I had my cardiac CT angio. And also it is because a lot of time the coronary artery disease patients, they also have renal problems. It's a biomarker, the EGFR is a biomarker of coronary artery disease. So in this sense, it is really important that for these studies that we target isosmolar agent, so we have better cooperation with our patient. And I'm going to remind you, I think it is really important to remember this very nice and useful and handy guidelines issued in 2018 by the European Society of Urology. And in the beginning, they talk about the different adverse effects, but I'm going to go to remind to everybody that pre-medication is not required because there is no good evidence of effectiveness. So do not give so much and destroy the metabolism of diabetic patient giving cortisone, because it's not going to do anything. We have to train ourselves and be ready to have our resuscitation table on the side and do ALS and ILS and be able to resuscitate, because in case that there is anaphylaxis, we have to be able to resuscitate, and cortisone cannot do it. It's adrenaline, and we have to have a team, especially if we're not in a hospital setting, to be able to change all this. Also important is isolated hypotension and vasovagal reaction, because they happen a lot because we give nitrates and we give beta blockers, and then the study finishes, and then the patient loses all the anxiety. He realizes how easy it was, but the drugs stay, and it's very easy to have a syncopic event. We have to be able to deal with it, to give fluids and atropine if needed. And I think about the late adverse events, which has to do with thyrotoxicosis and nephrogenic systemic fibrosis in case of MRI, we have to ask our patients about, they will know if they have Graves' disease or automaticity that might cause thyrotoxicosis. Also be very aware and acquire recent creatinine before you give contrast. Try to give the least amount of contrast. Currently, I give about, in a study, the patient's body weight minus 20 or 30 mL. We can achieve, with a good cannulation, we can achieve very low amount of contrast. And some more things about renal issues that we have to be careful about. And again, in this situation, whenever a renal problem is an issue, isosmolar agents have a much better profile to be used in these cases, like iodexol. And my last slide is about a suggestion that we have radiologists and cardiologists have to be able to regulate all this contrast, heart rate, scanning parameters. We have to be, everybody that wants to do a cardiac CT to follow this path, they have to be familiar with these principles to be able to regulate and achieve very good heart rates. Otherwise, they're going to suffer. And we cannot give it to the cardiologist, okay, you're gonna see the heart rate and I'm gonna do the study. Because if something goes wrong, then whose fault is it? I mean, somebody has to have the responsibility. Thank you very much.
Fantastic presentation. Thank you very much, Dr. Kostas Michailidis, for this excellent presentation. And you covered all the topics, a lot of tips, a lot of information about how to better prepare our patient. And I think that this is the key for the examination.
As you say it, Alex, you know it very well. You do it. You do the same thing. We pretty much practice in a very similar way. I think this topic is not very nice to listen to. It's not very exciting, but it is as much as not fun it is so crucial. I mean, in order to achieve a good diagnosis, you need good images and you need low contrast study in order to get referrals. I mean, it's something that goes in a virtuous cycle that every single component is important in order to have a successful service, to have happy patients, good images, low contrast, no complications. I think it has to be done like this, that somebody has to, a team, of course it cannot be one, it has to be a very good team of radiographers and nurses, and everybody in the team can give a lot in this. Everybody, and the industry can support us a lot with this. I think it is very important, as I said in the beginning, that all of this changed my perspective when General Electric supported me with a very good application specialist, and that changed everything for me. So growth and development comes for us from the industry in these technical issues, and they have to support us.
Of course, this is the message. I don't know.
No, thank you, Dr. Michailidis. I don't have something special to add here. Dr. Michailidis covered everything.
Yes, a last comment. You perform a calcium score, Kostas, to every patient?
To every patient. Of course, not to patients with stents and bypass grafts. In this case, because in the stents, sometimes I will do it only in the upper lung fields to see if the patient is again a smoker. If we did not convince them to quit smoking, then I will do the upper lung fields, because smoking is a comorbidity for both cancer, of course, and coronary artery disease. And we have to serve our patients, and we have to do it all. I think it is very essential that we do it. Sometimes if it's a non-smoker, I might leave some part of the lungs outside.
Okay, and here we have a question, Thanos, if you want to proceed, from the audience.
Yeah, of course. The question says, do you always proceed to coronary angiography if the calcium score is high?
Look, I have this algorithm. So it is 3 different things that make a study good or bad. It's calcium score, it's BMI, and arrhythmia. And then it is symptoms. So for an asymptomatic patient, even if they have high BMI and high calcium score, I will proceed. Because an asymptomatic examinee has lower pretest probability of having something significant. However, if there is a symptomatic patient that has any of these 3, then I will stop with the calcium score. I do it quite frequently. So if there is a high calcium score and arrhythmia and the patient is symptomatic, I'm going to stop. If it is some low calcium score and high BMI in an asymptomatic examinee, I'm going to proceed, even with a BMI of 55.
Okay, thank you. There is one more question.
One more question, yes. It is related. I think that you answered Kostas Here a colleague asked what with arrhythmia patients. Of course, you mentioned that arrhythmia is a problem for this exam.
Okay. I have to say something about this. I did not mention before that high arrhythmia, especially atrial fibrillation, needs retrospective studies who have to do retrospective in atrial fibrillation. However, if the patient has extra beats, so extra systolic activity, and it's not very high, I suggest prospective, because most modern scanners now, they have arrhythmia detection. They're going to skip the arrhythmia bit rather than retrospective. So in atrial fibrillation, retrospective. In extra systoles, if there are not too many, prospective.
Perfect. Thank you very much.
Thank
I
you
don't
very
know
much.
if we have a question from the audience, if there is... yeah,
Yes, please.
Use your microphone. Yeah.
Okay. Congratulations for your very nice talk. My name is Mariana Vlechou. I'm a radiologist from the University Hospital of Larissa. And I would like to ask you a technical question. We all know that we need multi-slice scanners, like 64 slices or more. So I would like you to comment on how important is the software related to multi-slice CT scanners, and now that we have the availability of slices like 640, what are we supposed to expect from such high score slices, I would say?
Thank you very much, Professor Vlechou. It's an honor to have you here today. Okay, about, I think 64 slice scanner is sufficient for most services. The higher amount of detector rows has to do with how much, what amount of patients want to scan. Because one of the things it is, maybe you get a lot of referrals, but right now, as you said before, there is a very big lack of radiologists and cardiologists to report the method. So you cannot do, even if you get 200 referrals per day, you cannot perform because you do not have the person to report. Now, in this, I think that in a hospital setting, it is more important to have these very high row scanners, the 320 or 640 or 256, to be able to perform single bit because you can serve also the acute service like this. With lower row scanners, you can achieve high quality images, very low doses, but you have to have, you cannot have very high output in patients, and you cannot do everything. And of course, the future is perfusion. And of course, one bit perfusion or one slice of perfusion, one volume of perfusion at the same time has a very high added value than scanning the myocardium across. Even in 1.5 or 2 seconds, this thing changes, it creates a perfusion gradient from the upper part of the scan to the lower part of the scan. So I think everything is good. Modern scanners with high technology, but mostly have to do with the people that use them, the radiographers, the cardiac CT team, to achieve the targets in quality and dose.
Many thanks, Kostas. Thank you very much.
And now let's proceed to the next presentation with Dr. Alexandros Kalifatidis. Dr. Alexandros Kalifatidis is a radiologist with subspecialty in cardiovascular imaging and the leading person in cardiac imaging in Greece for cardiac CT and cardiac MRI. He is a board-certified cardiovascular imaging radiologist from European Board of Cardiovascular Radiology and an active subcommittee member of Education, EBCR Committee, and the FEACVI and SCMR member. Thank you, Alexandros Kalifatidis. The stage is yours. Thank you.
Thank you very much, Thanos, for the kind introduction. And once again, I would like to thank the people from General Electric Healthcare and congratulate for this scientific event. Proceeding with my presentation, of course, we know that stress is not good to our daily life, but why do we need stress in our patients? Dr. Theophilogiannakos showed before, and Dr. Michailidis, they talked about ischemia, and we are all less or more familiar with this ischemic cascade and the progression of coronary artery disease with the plaque formation and the stenosis of the lumen, and starting with perfusion abnormalities, regional diastolic dysfunction, progression with regional systolic dysfunction, ischemic ECG changes, and angina pectoris. And we have tools in order to assess people in all these stages, different techniques. We will speak for all these techniques later on. And, but we know that stenosis is not always ischemia. And many times we are facing cases like this. Kostas will show us later with cardiac CT, but some clinical examples here with different types of plaques, different degree of stenosis, here a patent stent, but afterwards stenotic lesions, or cases like this with severe calcification. And we cannot be sure if these stenotic lesions are relevant and if they are causing ischemia. And in this part, I would like to I would like to put this first quiz question. I would like from you to see this scheme and try to estimate which stenosis. Here we have a normal coronary vessel. The second one, we have a high degree of stenosis. Here, a moderate stenosis. Here, we don't have a stenosis, but we have a diffuse atherosclerosis. Here, a combination of diffuse atherosclerosis and moderate stenosis. And here, another example with no severe stenosis. Could you estimate and try to answer which stenosis reduce the coronary flow reserve significantly? 4 or 6? Answer C, it is 2, 4 and 5, and D, 2, 5 and 6. We will have a few more seconds about voting. I think that we have the voting system running. And we are ready? Okay, let's wait a little bit. It is a quite tricky question. I don't know if you can see afterwards what the audience voted, Melina?
Yeah, and I think in order to help the audience, at the bottom of your screen, there are two boxes, one with Q&A and the second one with polls. Please choose the polls in order to vote for the question.
Okay, I think that we can proceed. And the answer is C. And we can see here, of course, we can estimate that this severe stenosis can reduce significantly the coronary flow reserve. But also here that we don't have any significant stenosis, but we have diffuse atherosclerosis, and also in this case we have a combination of diffuse atherosclerosis and severe stenosis. And just I would like to mention that this dissociation between the anatomic and the functional severity of the stenosis could happen in human because when we have a diffuse atherosclerosis and remodeling of the coronary arteries. So after showing all this, why do we need the stress? Already clinical trials, the CMARC study 2, have shown that non-invasive functional imaging strategies reduced unnecessary angiography compared with guidelines directed care. And why we can use stress MRI? As we can see from this publication and this meta-analysis, stress MRI has a high diagnostic performance, also in comparison with PET and cardiac CT, but better diagnostic performance in comparison with echo and SPECT. So it could be a very useful imaging technique. Also from this study, CMR showed that had a greater sensitivity than SPECT, especially when we have to deal with women, and there were no differences between men and women, unlike SPECT. And don't forget that also it is a technique with no radiation, so very important advantage of the technique. Also, it has been shown that especially in patients with three-vessel disease has a better diagnostic performance than SPECT. Here from the literature, we can see an example with no abnormality, shown abnormality during stress and rest SPECT technique, but with CMR with this high spatial and temporal resolution and high contrast and signal to noise ratio, we can see these perfusion defects almost circumferential due to three-vessel disease that during stress they are disappearing, so another advantage of the technique. Regarding prognostic information, there are studies that have been shown the prognostic value of the technique in patients with without known coronary artery disease and in patients with reduced left ventricular function. And this study from States showed that the prognostic value of CMR when evaluating patients with chest pain, and showed that patients without CMR ischemia or late enhancement experienced a lower incidence of cardiac events and little need of coronary revascularization, and low spending on subsequent ischemia testing. And don't forget this study, MR Inform, a few years ago that showed that CMR we can use CMR as a gatekeeper, and showed that as we can use CMR as a guide for the initial management of patients with stable angina and an intermediate to high risk for coronary artery disease, in comparison with invasive angiography supported by FFR, and this study showed that both techniques are safe and result in a low total event rate, but with the advantage that CMR significantly reduces unnecessary interventional procedures. And what about cost? This is another important thing. Also, there are studies that shows the cost effectiveness of this method, and we can use CMR as a gatekeeper in order also to reduce the cost. Some things and tips before the exams. Of course, it is important to speak with the referral clinician to know our patients, their history, what we want to assess. For patients, it is important to fill an MR questionnaire. We must know if they have any metallic elements. We must know about their renal function, and of course other important information from their history. And it is important for the patient to sign this consent in order to proceed with the method. We have to keep in mind that regarding the metallic coronary stents or prosthetic valves, even the older Star-Edwards valve, there is no contraindication, especially for 1.5 MRI scanners or rings for valve annuloplasty. chemistry. The only problem could be that we could have some artifacts from this metallic prosthesis. Contraindication could be for some metallic things and fragments or neurosurgery clips and some pacemakers and defibrillators, especially for the old generation, because now there are MRI conditional pacemakers and defibrillators, but also there is a study that showed that MRI could be safe for someone with a device implanted after 2000, as long as the device is checked before and after the procedure and its pacing function is monitored during the scan. In any case, if you have any difficulties or you want to find some additional information, you can search here in this site, mrisafety.com, and you can put all the technical characteristics of your device and see if it is safe or conditional or unsafe in order not to proceed. It is important for our patient to be calm before the examination. He will be stressed afterwards with the medication, but before the examination we have to explain and talk with the patient to give him all this information, how will be the procedure, how he will feel in order to not to be panicked during the examination. These are tricks that can reduce a patient's anxiety. We can use ear heads in order to let him hear some music in order to relax during the procedure. And after all this, we are ready. And after checking that he has a good preparation, and what includes this good preparation, the patient should avoid caffeine, chocolate, bananas, and energy drinks 24 hours prior to the examination. Avoid to take theophylline, dipyridamole, and nitrates. Not to smoke for 24 hours if it is possible. And patients should not eat 3 to 4 hours prior to the examination. We will choose the safest contrast, and of course now there are we are using only contrast with cyclical structure. There is a specific contrast dose according to the body weight of the patient, and with this injection rate. We have to prepare all this before we will proceed with the examination, and we have to know patient's renal function in order to use the least and the lowest dose of our contrast in order to avoid a situation like this, like nephrogenic systemic fibrosis, which is a very rare complication, but we have to keep in mind. And in patients with severe renal failure, we can consider hemodialysis within 2 hours after contrast agent administration, although it is not proven to prevent NSF. The stress agents that we can use, afterwards Dr. Ninios will talk with much more details. We can use adenosine with a specific dose formula, as we can see here. Or regadenoson, which is a bolus dose, regardless the body weight of the patient. For adenosine, we have to cannulate 2 veins. This is maybe one disadvantage of the technique. We don't have this disadvantage with regadenoson. We can have only 1 vein access, and from there we will give regadenoson, and after we will proceed with contrast administration. For adenosine, we are using pump infusers like this, and as I said before, with regadenoson, there is a single bolus dose with a flash of saline after the regadenoson administration. I will not stand with details in these contraindications. I think Ilias afterwards will explain more. And here is the environment of the magnet where our patient we will lie down, and we are using dedicated body coils, as we can see here, and the headphones, and this button that our patient can press if he will not feel good enough. Here is how we are putting our patient into the magnet, and here how we are putting the patches in order to get the signal from the ECG, because as Kostas before explained, it is an ECG-gated method. Here, once again, how we are putting our patient, we are talking to him, we try to make him feel calm. It is very important to monitor the vital signs of our patient during the scan, and a few minutes after the scan. Here we can see okay, every 3 minutes for adenosine and regadenoson, the blood pressure, the ECG, it is very important, and the oxygenation of our patient in order to see if there is any problem. And of course, if there will be any problem, we must be ready in order to alert our cardiac arrest team, call for help. We have to keep in mind that only BLS can be performed in scanner room, so we have to be fast enough to remove our patient from the scanner. We have to keep an MR-compatible trolley adjacent to the scanner, and we must be ready to act in order to proceed with resuscitation with our patient if it will be needed as fast as possible. And starting the examination, we are putting all the information of our from our patient, the body weight, the height, and the information for his age and his name, of course. We are starting with the first localizers, and we are proceeding afterwards with the function, dedicated sequences, SSFP, excellent sequences in order to see the heart in all axes, short axis and long axis views, and afterwards we are planning the perfusion scan, the first past perfusion that requires high temporal and spatial resolution sequences. We are proceeding with a multi-coverage of the left ventricle, usually 3 or 4 short axis slices, putting like this, and trying to avoid the base and the true apex, because we need much more myocardial muscle to assess. In addition, sometimes we can have an additional 4-chamber view, but usually we are using these 3 or 4 short axis slices. And after we have scheduled our scan, we are proceeding with the injection of the gadolinium in the peak phase of the stress, approximately 2 to 3 minutes with adenosine, and after 50 to 60 seconds after regadenoson. And the idea is to, with these dedicated perfusion sequences, to see if there is any mismatch and signal difference between the normal and the hypoperfused myocardium, so to see if there is any ischemia. And by knowing the territories that they are supplied by the coronary arteries, and this 17-segment myocardial segment, according to the American Heart Association, we can estimate the responsible for the ischemia vessel. And we have to keep in mind that the relevant ischemia is considered when we have 2 or more segments of the 16 myocardial segments. Here it is 16 because the 17th segment, it is the apex we are not assessing with the short axis slices. And of course, the final step of our examination is the late enhancement in order to see if there is any abnormal enhancement, infarction, etc., etc. Here is once again in this scheme a dedicated protocol. So the localizers, we can firstly, if we want to save some time, proceed with stress perfusion technique. Afterwards, after the stress, in order to save time, we can proceed with the ventricular function and the short axis slices. We can add a rest perfusion sequence and some long axis functional slices, and finally the late enhancement. Or we can firstly start with the cine images. We can add some mapping techniques. There are modern techniques in order to see the global fibrosis or edema. It depends from the clinical status of our patient, and after to proceed with other sequences. And if you would like to see some more information, there are already standardized protocols that explain to us how we can proceed with dedicated sequences for this examination. Some tips that before proceeding with the stress perfusion, usually we are running this test, this dummy scan without contrast, in order to see if there are any artifacts, in order to see if we have the center of our slices, the heart of our patient, in order to avoid situations like this, these folding artifacts that could affect our diagnosis. And for the myocardial perfusion imaging, I would like once again to mention that we are using sequences with high temporal and spatial resolution. Usually we have this gradient echo sequence or SSFP sequence. They are sensitive to one sequences that have a high contrast and signal to noise ratio, so very high diagnostic quality for our patients. And also we are using saturation pre-pulses in order to achieve a better contrast to noise for the contrast that it is in the myocardium of our patient. And here you can see the initial stage. Here we don't have yet the contrast. In the first phase, the contrast passes from the right ventricle to the left ventricle and after to the myocardium. And in this way, we can see if there are any perfusion defects. There are new algorithms that can reduce the breathing. During the first pass, we ask for the patient to keep his breath, but after the second perfusion pass, we ask the patient to continue and breathe very calm and normally. But there are also algorithms that help us to reduce this movement from patients' breathing. There are movement corrections algorithms, and we can see that we can improve our diagnostic confidence also with the use of these algorithms. Other tip, if our ECG is not good or we have arrhythmias, we have to keep in mind that we can use pulse oximetry sensors in order to get signal. It is our final option, but we have to keep in mind of this. And criteria for a good stress, what are the criteria? A heart rate rise of at least 10 BPM, a blood pressure drop of approximately 10 to 15 millimeters of mercury. When patients experiencing symptoms such as pressure on the chest and this splenic switch off, it is a sign I will show you just afterwards. Here, this sign during stress, we can see that the signal in the myocardium is bright with the contrast, but in the spleen is dark, and this is during the stress phase. And during rest, almost in the same time, we have a similar perfusion of the myocardium and spleen. And this is a sign that we can use only with adenosine, but not with regadenoson. And what about the post-processing and our report? There are already standardized information about the standardized image interpretation and post-processing in with stress perfusion. Basically, in our routine and clinical practice, we are based on the visual analysis, and it is much more widely used for clinical scenarios. It is important to displace the stress, rest, and late gadolinium images side by side to see if there are differences in the stress and rest phase, and afterwards to see if there is any enhancement. And here is an example. We can see at first during stress this perfusion defect in this part, these dark areas in the territory of LAD and circumflex artery that resolves during rest. So we have a positive stress perfusion test, and afterwards we can see that we don't have any late enhancement in this example. And we have to keep in mind that a perfusion defect occurs when the contrast arrives in the left ventricular myocardium, when it is more than 2 pixels wide, when it persists beyond peak myocardial enhancement and for several heartbeats, more than 4. It could be subendocardial or transmural. It is present at stress but not at rest, as we have seen before, and it conforms to the distribution territory of one or more coronary arteries. On the other hand, dark rim artifacts are most prominent when contrast arrives in the left ventricular blood pool and persists only transiently before the peak myocardial contrast enhancement. And usually they are approximately 1 pixel wide. And here we see 2 examples, a characteristic stress perfusion defect in these areas. But here we can see this dark rim artifact, a very thin layer of dark signal that it is due to an artifact. Before finishing my presentation, just to mention that beyond the visual assessment, we can use techniques with semi-quantitative, but now even quantitative perfusion. And why this could be a benefit? Because we can measure, we can have numbers, we can measure the myocardial blood flow and myocardial perfusion reserve. We can use maps and see the differences between the stress and the rest phase. Here today we have a very good friend, Kostas Kasapidis. We will discuss later about these techniques from how we can perform it. You can find additional information here. You can scan this barcode and see how we can proceed according to the scanner that you have, according to the contrast media that you will use, and the hyperemic agent that you will use, adenosine or regadenoson, and you can see step by step how we can organize your stress scan. With I would like to finish with 2 clinical cases that Kostas and Circle provided to me, kindly provided to me. This is a case with one vessel disease. We can use at firstly the visual assessment, and we can see, I don't know if it is clearly seen in this example. This is the rest and stress phase. We can see this perfusion defect in the inferior wall of the left ventricle. We don't see any enhancement. We see normal function with the cine sequences, but afterwards with color maps we can see this abnormal area. With orange it is normal perfusion. This is an abnormal area with ischemia and this defect, but also we can have numbers with polar maps, and we can see the differences between the rest and the stress phase. And one final case that maybe this technique is much more beneficial when we have a 3-vessel disease and we cannot be sure visually if there is any perfusion defect. We can use these polar maps and these calculations, and in this example we can see that there were abnormal myocardial blood flow in the 3-vessel territory. So this is quite promising and under development technique, but already used in some dedicated centers. I think that it will play a very important role in the near future. And with all this, I hope that I was not quite off from the time. I would like to thank you for the attention. Thank you very much.
Thank you very much, Dr. Kalifatidis, for this thorough presentation and the tips you provided us. I think now I can say that I'm not stressed about to see how we could proceed to this examination. We have some interesting questions, but for the moment, let's stick to one. And at the end of the session, we can review the rest of the questions. So, the question says, if the perfusion defect appears at stress, is it necessary to perform the rest test?
Okay, this is a very good question, and I would like to mention that usually and routinely, in the most of the cases, we are not performing rest perfusion, because if it is very clear, the perfusion defect, also we can make the match with the late enhancement, as I showed before. And if we don't have late enhancement and we have a clear perfusion defect, it is not necessary. Of course, we can skip the rest perfusion. But during the stress phase, if it is clear, we can skip the rest perfusion and proceed with late enhancement in order also to save time with our protocol. Because we know that we have in our clinic one magnet. We try to make as much as more cases. So, of course, we can skip it. We are proceeding with rest if there is a doubt for the perfusion defect, or we want to clear a finding and we want to be much more confident. Then we are proceeding also with the rest technique.
And one more question. How much time do you need for a stress MRI perfusion test?
Actually, as I showed before with the protocol, if we will proceed immediately with the stress perfusion sequences, we can make 25-30 minutes. On the other hand, if we are adding some sequences like mapping or steer sequences in order to see if there is any edema, approximately 45 minutes you can finish and you have all the information.
Excellent. Thank you one more time. Thank you for this excellent presentation.
Thank you very much.
I think it's time to proceed to the next speaker. Dr. Ηλίας Νινιός is interventional cardiologist at the European Interbalkan Medical Center at Thessaloniki in Greece. His main interest is in cardiac imaging, in cardiac MRI, stress echo, and transesophageal echo. He is also an investigator in international clinical trials and member of several cardiology associations. So, Dr. Ηλίας Νινιός, the stage is yours. Thank you.
Thank you very much, Anno. Ladies and gentlemen, thank you very much. I'm very happy to be here with you and with you, Alex, because we used to work together for many years. I think it's very important for the cardiologist and the radiologist to work together, because we have to walk together, because everybody gives something in that job. As I say, the radiologists, they know every artifact with his name, and the cardiologists, sometimes they know better the clinical scenario, but it's very important to collaborate. Is a stress MRI really, or maybe a rich man's stress echo, or is it a useful functional test? But first things first, and cardiac MRI can give us a lot of information. We can take information about the anatomy of the heart and the aorta. We can have a lot of information about the morphology of the left ventricle, the ejection fraction, the right ventricle. We can perform tagging. We can assess the flow in the pulmonary artery and the aorta. We can evaluate the left ventricle for edema, and of course perform first pass perfusion and assess for ischemia and detect myocardial infarction, but also scar due to other causes like myocarditis. And in 3 words, stress MRI evaluates ischemia, viability, cardiac function with no exposure to radiation. And that's very important. But a big question is, what's the best type of functional imaging? There is maybe no answer, but we know that so far stress MRI has a fantastic sensitivity and specificity of more than 90%, better than with SPECT and with stress echo. And compared to CTCA, that's a similar sensitivity, but the specificity is much more better. And stress MRI is based on the first pass perfusion. We actually evaluate the signal difference between the normal and the hypoperfused myocardium. It means the normal myocardium appears gray and the hypoperfused appears to be black. And that's all done either with dobutamine or with the intravenous administration of vasodilators that cause an increase in the coronary blood flow and help us assess the myocardial perfusion either visually or with the use of software tools. But so far, the golden standard for the detection and the judgment of the hemodynamic relevance of a stenosis in the coronary arteries was the invasive coronary angiography and the use of FFR. And if somebody had asked 10 years ago the question FFR or stress MRI, it would be a joke. But then came the MR Inform study, as Alexandros said, that was planned to show that the use of stress MRI was not inferior to the conventional angiography plus FFR. And they divided the patients into 2 arms. The one arm, the half of the patients received invasive angiography plus FFR if there was a stenosis more than 50%, and the other arm received only a stress MRI and a coronary angiography only if there was a perfusion defect. And they show that there was actually no big difference regarding the MACE, and that this strategy was a good strategy for the people with suspected coronary artery disease. But it had been shown years ago with the MR impact study that compared to the SPECT, the stress MRI was even better and more accurate. And with a multi-center study from 13 centers and over 2,000 patients, it had been shown that a negative for ischemia and for late enhancement stress MRI predicted a very good primary outcome compared to the presence of ischemia and late enhancement. Actually, the patients with ischemia and late enhancement had a 4-fold higher annual primary outcome rate and a 10-fold higher rate of coronary revascularization during the first year compared to the people without ischemia and without late enhancement. And especially for regadenoson, it has been shown that there is a great prognostic value if we have no perfusion defects compared with the presence of perfusion defects. And it has been shown also that if we have no resting CMR abnormalities, we have very good prognosis. But we can also perform a risk stratification with regadenoson stress MR. In the absence of inducible ischemia, we have fewer events and major cardiac events compared to the presence of ischemia. But with a stress MRI, we can also assess the viability of the left ventricle, and that's a big question before we plan a major cardiac operation or a CTO. And Kim showed 20 years ago that the likelihood of recovery of the function of the wall is actually very, very low if the transmurality of the scar is more than 50%. And that's an example of a patient with a hypokinesia of the inferior wall. And we see that there is actually, in the right panel, there is no scar in the inferior wall, and that's a viable inferior wall. And when we perform a stress MRI, we assess the hypoperfused myocardium compared to the perfused, to the normally perfused myocardium. But not only. We do not only assess the ischemia due to the coronary hypoperfusion due to coronary artery disease, but also due to hypertrophy. For instance, if we have a hypertensive heart disease or hypertrophic cardiomyopathy. In that example, we have a circular perfusion defect in the absence of coronary artery disease or scars, and that's due to the hypertrophy of the left ventricle. We have to be very careful because of the dark rim artifact that's present during the stress and during the rest perfusion, and is something different than the perfusion deficits. And as Alexandros said, we have a good friend when we perform an adenosine stress MRI, and that's a splenic switch-off. We can be sure that the stressor has done the job and has worked. But that's the case only when we perform an adenosine stress MRI, not for regadenoson. And a big work in progress is the evaluation of semi-quantitative and quantitative stress MRI perfusion tools. But the question is, how can I know, how can I be sure that when I use a regadenoson that it has worked? And the answer is, I look at the heart rate, and I have an increase in the heart rate for over 30 until 40%. And then I'm sure that the medicament, that the stressor has done the job. And we have 4 different stress agents, or 4 main stress agents in the stress MRI. Dobutamine and the 3 vasodilators, dipyridamole, adenosine, and regadenoson. And starting from dobutamine, it activates the beta-1 receptors, and they produce an increase in the adenylyl cyclase and an increase in the CAMP, and then an increase in the calcium concentration and a better contraction. Dobutamine comes from the good old stress echo, and we use additionally also atropine if needed. We have a target heart rate and the stress MRI with dobutamine has a good sensitivity and specificity of 86–85%. The good thing is that we can assess also the viability of the left ventricle through a different pathway, not only through the extension of the scar, but also through the low-dose dobutamine stress. And as an example, with dobutamine stress MRI, but when we talk about the vasodilators, we know that adenosine is activating A1, A2, and A3 receptors. And that means it causes a coronary vasodilation, but also a negative AV conduction, and negative chronotropy and inotropy, but also a bronchoconstriction. The good thing with regadenoson is that it's very selective, and it activates only the A2A receptors, producing only a coronary vasodilation. And if we compare regadenoson to adenosine, we see with regadenoson we have a fixed dose, with adenosine we have a weight-based dose. The duration of the infusion is too short, 10 seconds, and the duration of the infusion in adenosine is 3 to 6 minutes. And the time to maximum hyperemia is half a minute, and with adenosine 2 to 3 minutes. Stress MRI with regadenoson is safe and has a very good tolerability. It has been shown that there are just few symptoms and minor symptoms, dyspnea, chest discomfort, and headache. And again, one single line, it's maximum hyperemia in 30 seconds, an easy administration, and duration of exonas maybe 10 or 15 minutes, and vasodilatation is comparable to adenosine. Our experience in Diαβαλκανικό, Interbalkan Medical Center with Lydia Karogiropoulou is excellent. We had performed it fast in 2 years, 55 stress tests with regadenoson, and we had actually no major side effects. People had just headache or chest discomfort for a couple of minutes or 5 minutes, and we had excellent results. We are very happy with that. And before the examination, it's very, very important to avoid coffee, tea, and chocolate for 24 hours. We use one line, one intravenous line, and the side effects are less than with adenosine. The formal protocol is to plan the scout, then perform the stress test, then give intravenously aminophylline if needed, then perform the SNE, and then the rest perfusion and the late enhancement. Actually, most of the people take the SNE first, then perform the stress test, and then the late enhancement, and they compare the perfusion deficits of the stress perfusion to the late enhancement images. It has been shown that both adenosine and regadenoson, they affect positively the LV ejection fraction, and they act, and regadenoson acts even if we give aminophylline and wait 10 or 15 minutes. And that's a point. Maybe that's the reason why a lot of people avoid the rest test with regadenoson. A very important thing is that we don't have to buy an infusion pump for the MRI when we administrate regadenoson, because we can do it with the IV injection in 10 seconds. And if we compare the vasodilator effects of regadenoson in stress MRI to dipyridamole, it's better, and it's equally to adenosine. And again, it's a fixed dose. We can give it in 10 seconds injection, and we can induce a good hyperemia 1 minute or half a minute after administration. It's very good tolerable, and we're allowed to perform a stress MRI with regadenoson also to people with COPD, asthma, and obesity. And ladies and gentlemen, I think stress MRI is an excellent one-stop shop for the cardiological patients. It gives us information about the anatomy, the function of the LV. We can perform a stress test. We can detect the fibrosis. Also, we can assess the function of the valves, and we can also have information about the aorta. But for the cardiological patients, it's very important to avoid the diagnostic odyssey through the stress test, and then stress echo, normal echo, contrast echo, or SPECT, and then back to the cath lab, and coronary angiography, standing or not standing, or FFR. I mean, it's a lot of costs, and also for the patients, it's a contrast and radiation exposure. And if we can avoid all those dangers for our patients with a good one-stop shop, it would be a very good idea. Thank you.
Thank you so much, Ilias, Dr. Ninios, for this fantastic presentation. And in the final slide, you showed us that it's not, in this case, it's not the case of enjoying the route, but we have to go immediately to Ithaca if it is possible. So the point is to choose the right test in order to get the right diagnosis. Fantastic presentation. And I think that we have, Thanos, time for a short question.
Yeah, a short and quick question. Please.
Yes, we are very good.
A short coffee, Alex.
We are very good on time, but we have a question from a colleague, Goran Banusic. I think, sorry if I'm not telling right the name. The one question, I think it has already answered, but it is how to see if stress rest is good for patients that have stress with regadenoson. Mm-hmm. I think, Ilias, that
we have a rise in the heart rate and a blood pressure drop, and the rise of the heart rate is maybe 40%. Mm-hmm. It's clear from the first minute that
and some
you
chest discomfort, probably the clinical signs
yes.
also.
Headache or chest discomfort is always there.
Exactly. And one related with this final question, are you using aminophylline in order to...
No, we don't. Mm-hmm, we don't use it routinely. We perfuse a stress perfusion, and then we take the rest images. We avoid to take the rest images with perfusion. We just take the late enhancement.
Exactly. As we discussed before, it's quite confident most of the times to get only the stress phase. Mm-hmm. And only in some few cases it is necessary to compare for the visual assessment.
Excellent. So thank you very much, Dr. Ninios. And I think it's time for a break, Dr. Kalifatidis. Let's come back at 5:30 Eastern European Time or 4:30 Central European Time. The watch will be on your screen. Thank you.